Let's talk about the drugs that are commonly used for heart failure. Heart failure results when cardiac output is inadequate for the needs of the body. A poorly understood defect in the cardiac contractility is complicated by multiple compensatory processes that further weaken the failing heart. Drugs which are used fall into three major groups with varying target and actions. So we have positive inotropic drugs, vasodilators, and miscellaneous drugs for chronic failure. For the positive inotropic drugs, first and foremost, do remember cardiac glycosides including digoxin. Then we have beta agonists, dobutamine. They are actually beta 1 agonists. And then we have phosphodiesterase inhibitors like milrinone, and vasodilators include phosphodiesterase inhibitors, nitroprusides, nitrates, and hydralazine. And loop diuretics, angiotensin inhibitors, nizatide, segubitril. Segubitril is basically an ARNI, which is angiotensin receptor neprilysin inhibitor. And then we have SGLT2 inhibitors. For the miscellaneous drugs, just include loop diuretics, angiotensin inhibitors, nizatide, segubitril, SGLT2 inhibitors, and also add the beta blockers, and also potassium-sparing diuretics like spironolactone. Heart failure is extremely serious cardiac conduction, which is associated with high mortality. Fundamental physiological effect in heart failure is a decrease in cardiac output, which is relative to the needs of the body, and the major manifestations are dyspnea and fatigue. The causes of heart failure are still not completely understood. In some cases, it can be ascribed to simple loss of functional myocardium, as in myocardial infarction. It is frequently associated with chronic hypertension, valvular heart disease, chronic artery disease, and a variety of cardiomyopathies. More than one-third of the cases are associated with a reduction in cardiac contractility and ejection fraction, like systolic failure or heart failure with reduced ejection fraction. Another large group of cases is called the stiffening of the or other changes in the ventricles that prevent adequate filling during diastole. Ejection volume, stroke volume is reduced, but ejection fraction is normal. So diastolic failure hota hai. This is what we call heart failure with preserved ejection fraction. Remaining cases can be attributed to a combination of systolic and diastolic dysfunction. The severity of heart failure is traditionally indicated by the NYHA scale. ठीक है, इसमें ये होता है कि हमारे पास 4 steps होते हैं. First यानी step 1 होता है which is basically aggravated by maximal exercise यानी कि extreme exercise, and जो step 2 होता है it is aggravated by marked exercise. Step 3 is aggravated by mild exercise, and step 4 अगर हम classify करें तो ये होता है at rest पे symptoms present होते हैं. Natural history of heart failure is characterized by slow deterioration of cardiac function punctuated by episodes of acute cardiac decompensation that are often associated with pulmonary or peripheral edema or both, which is congestive heart failure. Reduction in cardiac output is best shown by the ventricular function curve, which is the Frank-Starling curve. अब इसमें वो कह रहे हैं कि बेसिकली यहाँ पर हमारे पास जो वाई एक्सिस है इसके ऊपर कार्डियक आउटपुट और वर्क है, एक्स एक्सिस के ऊपर एंडाइस्टोलिक फाइबर लेंथ है. तो बेसिकली वो कह रहे हैं कि नॉर्मली हमारे पास जो होती है क्या होता है कि the abscissa can be any measure of the preload, fiber length, filling pressure, pulmonary capillary wedge pressure. Ordinate is a measure of useful external cardiac work, stroke volume, cardiac output. In heart failure, output is going to be reduced at all fiber lengths. ठीक है, output reduced होगा at all of the lengths of the fiber. And the heart expands because the ejection fraction is decreased or filling pressure is increased or both. As a result, heart moves from point A to point C to point B, downwards and towards the right. Compensatory sympathetic discharge or effective treatment allows heart to eject more blood, and the heart points to the point C on the middle. अब कहते हैं कि जब हमारे पास ejection fraction decrease होता है ना HFrEF के अंदर, and diastolic fiber की जो length होती है वो increase हो जाती है, as shown by the shift from the point A towards the point B. ठीक है. Operation at point B is intrinsically less efficient than operation at shorter fiber lengths because of the increase in myocardial oxygen requirement associated with increased fiber tension and length. The homeostatic responses to depressed cardiac output are extremely important, and they are mediated mainly by the sympathetic nervous system and renin-angiotensin aldosterone system. अब हमारे पास जो है ना ये बड़ा इंपॉर्टेंट है. सबसे पहले ये है कि कार्डियक आउटपुट कम होगा तो हमारे पास क्या क्या चीज़ें होंगी. सबसे पहले क्या होता है कि कैरोटिड साइनस फायरिंग जो होती है वो कम हो जाती है, सिंपैथेटिक डिस्चार्ज इंक्रीज हो जाता है, हार्ट की फोर्स इंक्रीज हो जाती है, हार्ट का रेट इंक्रीज हो जाता है, आफ्टर लोड इंक्रीज हो जाता है, एंड फ्री लोड भी इंक्रीज हो जाता है. ऐसे कार्डियक आउटपुट कम और रीनल ब्लड फ्लो आल्सो गेट्स कम, and renin release increase हो जाती है, angiotensin 2 increase हो जाती है, preload increases, afterload increases, and remodeling increases. As a result of all of these यानी कि force rate and preload बढ़ने की वजह से cardiac output increase हो जाएगा by compensation. Increased blood volume results in edema and pulmonary congestion and contributes to the increased and diastolic fiber length. Cardiomegaly or enlargement, remodeling of the heart, and slower compensatory responses mediated at least in part by synthetic discharge and angiotensin 2 are common. Although these compensatory responses are temporarily going to improve the cardiac output, they also increase the load on the heart, and the increased load contributes to further long-term decline in cardiac function. Apoptosis is a later response and results in a reduction in the number of functional myocytes. Evidence suggests that catecholamines, angiotensin 2, and aldosterone play a direct role in these pathophysiological changes. Now for the therapeutic strategies. Pharmacological therapies for heart failure include the removal of retained salt and water with diuretics, reduction of afterload and salt and water retention by ACE inhibitors, reduction of excessive sympathetic stimulation by beta blockers, reduction of preload or afterload with vasodilators, and in systolic failure, direct augmentation of depressed cardiac contractility with positive inotropic drugs such as digitalis glycosides. Considerable evidence indicates that angiotensin antagonists and certain beta blockers and the aldosterone antagonists spironolactone and eplerenone also have long-term beneficial effects. ये सारी बात हो रही है HFrEF के अंदर, लेकिन first of all HFrEF के अंदर we are going to prefer using cardiac glycosides. The drug classes and targets. The use of diuretics. Current clinical evidence suggests that acute heart failure should be treated with सबसे पहले loop diuretic, उसके बाद and positive if severe prompt acting positive inotropic agents such as beta agonists or phosphodiesterase inhibitors and vasodilators should be used as required to optimize the filling pressures and blood pressure. Chronic heart failure जो होता है वो किस तरह ट्रीट करते हैं? सबसे पहले लूप एजेंट के साथ, एस इनहिबिटर के साथ एंड बीटा ब्लॉकर के साथ. अच्छा, digitalis may be useful in systolic if the systolic function is prominent. Necititide, which is a recombinant form of brain natriuretic peptide. अच्छा, ये vasodilator था. It has vasodilating and diuretic properties and it is heavily promoted for use in acute failure. A new combination of drugs जैसे कि ARNIs जिसको कहते हैं angiotensin receptor neprilysin inhibitor, जैसे कि valsartan और cigapitril और valsartan भी हमारे पास ARB होता है. Combines action of increased endogenous brain natriuretic peptide with those of the angiotensin receptor blocker valsartan. Okay, so digitalis glycosides are no longer considered the first-line drugs in the treatment of heart failure, however, because they are not discussed elsewhere. Okay, prototypes and pharmacokinetics. All of the cardiac glycosides are cardianolytes, which means that they have a steroid nucleus and a lactone ring. Most also have one or more sugar residues, justifying the designation as a glycoside. Cardiac glycosides used clinically are often called digitalis because several forms come from the digitalis plant or the foxglove plant. Digoxin is the prototype agent and the only one commonly used in the US. Digitoxin is a very similar but longer acting molecule. It also comes from the foxglove plant, but it is no longer available in the US. Digoxin has an oral availability of 60 to 75% and half-life of 36 to 40 hours. Elimination is by the renal excretion about 60% and hepatic metabolism about 40%. अब हम मैकेनिज्म ऑफ एक्शन की बात करते हैं. ये सबसे पहले क्या करते हैं? सोडियम पोटेशियम एटीपीएज पंप के थ्रू जो होता है ना को इनहिबिट करता है. सोडियम पोटेशियम एटीपीएज को इनहिबिट करता है. सोडियम पंप ऑफ द सेल मेम्ब्रेन. By digitalis, it is well documented and it is considered to be the primary biochemical mechanism of action. Sodium potassium ATPase जब inhibit होता है तो क्या होता है? Small increase in the intracellular sodium level हो जाता है. The increased sodium will alter the driving force for sodium calcium exchange by the exchanger. इसकी वजह से क्या होता है? Sodium calcium exchanger. So that less calcium is going to be removed by the cell. इसकी वजह से क्या होता है? सर्का के थ्रू या सार्कोप्लाज्मिक रेटिकुलम के थ्रू इंट्रासेलुलर कैल्शियम जो होता है वो इंक्रीज हो जाता है सेल के अंदर and upon release it increases the contractile force. Other mechanisms of action have been proposed for digitalis, but they're not as important as inhibition of ATPase. Consequence क्या होता है sodium potassium ATPase inhibition का? They are seen in both the mechanical and the electrical functions of the heart. Digitalis also modifies the autonomic outflow and action has effects on the electrical properties on the heart. जैसे यहाँ पर आप देख सकते हैं कि सोडियम पोटेशियम ATPase पंप है, सोडियम अंदर रिटेन हो जाता है और ये सेल मेम्ब्रेन है, ये हमारे पास सार्कोमेयर है, ये हमारे पास इंटरस्टिशियम है. सोडियम अंदर रिटेन हो जाता है और जो इंट्रासेलुलर सोडियम का जो लेवल होता है ना वो बढ़ जाता है. ठीक है, और फिर क्या होता है कि जो हमारे पास सोडियम कैल्शियम एक्सचेंजर जो होता है वो भी एक्टिवेट हो जाता है और कैल्शियम जो होता है ना उसका भी लेवल सेल के अंदर बढ़ जाता है. और क्या हो जाएगा कि ये हमारे पास फोर्स प्रोवाइड करेगा कॉन्ट्रैक्टिलिटी की. नाउ फॉर द ड्रग टारगेट्स एंड मैकेनिज्म एंड हार्ट फेलियर. सबसे पहले हमारे पास जो है जिसमें भी रीनल आएगा या सोडियम आएगा ना तो वो ज़्यादातर हमारे पास एक्यूट फेलियर के अंदर यूज़ होती है. अच्छा, रीनल सोडियम ट्रांसपोर्टर इनहिबिटर्स ये एक्यूट एंड क्रॉनिक हार्ट फेलियर के अंदर यूज़ होती है. और एस इनहिबिटर्स जो होते हैं वो और एंजियोटेंसिन रिसेप्टर ब्लॉकर्स ये क्रॉनिक फेलियर में यूज़ होती हैं. बीटा जिसके अंदर आएगा वो भी क्रॉनिक में. बीटा एड्रेनर्जिक रिसेप्टर्स क्रॉनिक में, बीटा एड्रेनर्जिक एंटागनिस्ट क्रॉनिक स्टेबल फेलियर में यूज़ होती हैं. एंड सोडियम पोटेशियम एटीपेज इनहिबिटर्स क्रॉनिक फेलियर में यूज़ होती हैं. बीटा एड्रेनर्जिक रिसेप्टर एगोनिस्ट्स एक्यूट फेलियर में यूज़ होती हैं. फॉस्फोडाइस्ट्रेज इनहिबिटर्स acute failure में यूज़ होती हैं. vasodilators acute failure, natriuretic peptide acute failure and neprilysin inhibitor plus ARBs जो होती हैं वो chronic failure में यूज़ होती हैं. Now for the examples of the drugs. सबसे पहले renal sodium transporter inhibitors की बात करते हैं. तो ये इसमें हमारे पास एक एग्जाम्पल आ जाती है लूप डायरेटिक्स की और पोटेशियम स्पेयरिंग ड्रग्स की. ठीक है, तो इसमें फिरोसिमाइड, स्पिरोनोलैक्टोन एंड SGL2 ब्लॉकर्स आ जाते हैं. और ये क्या करते हैं कि हर चीज़ में मोस्टली यही है कि प्रीलोड एंड आफ्टर लोड को कम हो जाते हैं. दे विल रिड्यूस द प्रीलोड एंड आफ्टर लोड. एस इनहिबिटर्स में कैप्टोप्रिल आ जाता है, दे रिड्यूस द प्रीलोड आफ्टर लोड एंड रिड्यूस रिमॉडलिंग. एंड एंजियोटेंसिन रिसेप्टर ब्लॉकर्स के अंदर लोसार्टन आ जाता है. इसका मैकेनिज्म ऑफ एक्शन सेम हो जाता है. बीटा एड्रेनोसेप्टर एंटागनिस्ट इसमें हमारे पास कार्बिडोल आ जाते हैं. दे विल ऑल्सो डू द सेम थिंग, यानी मैकेनिज्म ऑफ एक्शन सेम होता है. सोडियम पोटेशियम एटीपेज के अंदर इनहिबिटर्स के अंदर हमारे पास डाइजॉक्सिन आ जाती है. ये क्या करती है? इंक्रीज कैल्शियम एंड इंक्रीज कार्डियक कंट्रैक्टिलिटी. बीटा एड्रेनोसेप्टर एगोनिस्ट इसके अंदर डोब्यूटामाइन एंड डोपामीन ये इंक्रीज करती है कैल्शियम को, इंक्रीज करती है कंट्रैक्टिलिटी को. विजुअलाइटर्स नाइट्रोसाइड रिड्यूस प्रीलोड एंड आफ्टरलोड. फॉस्फोडाइस्टरेज इनहिबिटर्स मिलरिनोन विजुअलाइजेशन करवाती है इंक्रीज कंट्रैक्टिलिटी. नाइट्रोटेक पेप्टाइड के अंदर नेसेटिटाइड आ जाती है. विजुअलाइजेशन करवाती है रिड्यूस प्रीलोड आफ्टरलोड, सम डायरेटिक इफेक्ट. नेप्रिलाइसिन इनहिबिटर प्लस ARBs इसमें सिगापिट्रिल एंड वल्सार्टन आ जाती है. कंबाइन इंक्रीज BNP प्लस ARB इफेक्ट्स आ जाते हैं. द कार्डियक इफेक्ट्स ऑफ डाइजॉक्सिन. ठीक है, सो mechanical effects आ जाते हैं. increase in contractility evoked by digitalis results in increased ventricular ejection, decrease and systolic and diastolic size, increase in the cardiac output, increase in the renal perfusion. These beneficial effects will permit a decrease in the compensatory, sympathetic and renal responses. The decrease in sympathetic tone is especially beneficial. Reduced heart rate, preload and afterload permits the heart to function more efficiently. अच्छा, उसके बाद electrical effects आ जाते हैं. They will include early cardiac parasympathomimetic response and later arrhythmogenic actions, early responses. अच्छा, सबसे ये बहुत इंटरेस्टिंग है. PR interval increase हो जाता है which is caused by decrease in AV conduction velocity and flattening of the T wave in the ECG के अंदर. Effects of atria and AV node are largely parasympathetic mediated by vagus nerve and can be partially blocked by atropine. The increase in AV nodal refractory period is particularly important when atrial flutter or fibrillation is present, because the refractoriness of the AV node determines the ventricular rate in these arrhythmias. Effect of digitalis is to slow down the ventricular rate. QT interval will get shortened, inversion of the T wave and ST segment depression may also occur later. Toxic responses. एक तो हमारे पास AV block आ सकता है और DAD यानी कि delayed after depolarization आ जाता है. Increased automaticity, which is caused by intracellular calcium overload, is the most important manifestation. Intracellular calcium overload results in delayed after depolarization, which is evoked by coupling of sodium influx to calcium efflux. These after depolarizations may evoke the extrasystoles, tachycardia, or fibrillation in any part of the heart. In the ventricles, extrasystoles are recognized as premature ventricular beats. When premature ventricular beats are coupled with normal heartbeat in a 1:1 fashion, rhythm is called bigeminy. So bigeminy भी toxic effect होता है digoxin का. Clinical uses. Digitalis is the traditional positive inotropic agent used in treatment of chronic heart failure. However, careful studies indicate that these digitalis may improve the functional status, reducing the symptoms. It does not prolong life. Other agents like diuretics, ACE inhibitors, vasodilators may be equally effective and less toxic, and some of these alternative therapies do prolong life. Because the half-lives of cardiac glycosides are long, the drugs accumulate significantly in the body, and dosing regimens must be carefully designed and monitored. Atrial fibrillation. In atrial fibrillation and flutter, it is desirable to reduce the conduction velocity or increase the refractory period of the AV node so that ventricular rate is controlled within a range which is compatible with the efficient filling and ejection. Parasympathomimetic action of digitalis will accomplish this therapeutic objective कि वो conduction velocity को कम करके refractory period of AV node को बढ़ा देता है. Although high doses may be required, alternative drugs for rate control include beta blockers and calcium channel blockers, but they have negative inotropic effects. Interactions. Quinidine जो होता है वो interact करता है digoxin reduction in digoxin clearance and can increase the serum digoxin level if digoxin dosage is not adjusted. Several other drugs have the same effect like amidrone, verapamil, and others, but the interaction with these drugs are not clinically significant. Digitalis toxicity, especially erythmogenesis, is increased by hypokalemia, hypomagnesemia, and hypercalcemia. Hypokalemia has a dual erythmogenic interaction. It permits increased binding of digoxin to sodium potassium ATPase as well as directly potentiating the automaticity. Loop diuretics and thiazides may significantly reduce serum potassium and precipitate digitalis toxicity. Loop diuretics and thiazides क्या करेंगे पोटेशियम को कम करके digitalis toxicity को बढ़ा देते हैं. Digitalis induced vomiting may deplete the serum magnesium and similarly facilitate the toxicity. These ion interactions are important when treating digitalis toxicity. नजर आ रही है कि जो PVB है ना प्री मेच्योर वेंट्रिकुलर बीट्स शो हो रही हैं. ठीक है. अच्छा, अब हम बात करते हैं इफेक्टिव रिफ्रैक्टरी पीरियड के अंदर क्या होता है. एट्रियल मसल जो होता है ना वो पैरासिम्पैथोमाइमेटिक एक्शन के अंदर जो होता है कम हो जाता है. इफेक्टिव रिफ्रैक्टरी पीरियड कम हो जाता है एट्रियल मसल के अंदर. ये हमारे पास एक्शंस ऑफ कार्डियक ग्लाइकोसाइड्स हैं एंड कार्डियक इलेक्ट्रिकल फंक्शंस. एवी नोड के अंदर जो होता है रिफ्रैक्टरी पीरियड इंक्रीज हो जाता है और जो रिफ्रैक्टरी पीरियड होता है वो परकिंजी सिस्टम के अंदर भी डिक्रीज़ हो जाता है. कंडक्शन वेलोसिटी जो होती है वो इंक्रीज़ हो जाती है एट्रियल मसल के अंदर और एवी नोड के अंदर कम होती है, परकिंजी सिस्टम के अंदर नेग्लिजिबल होती है. ऑटोमेटिसिटी जो होती है वो एट्रियल मसल, एवी नोड एंड परकिंज सिस्टम सब के अंदर इंक्रीज़ होती है. ईसीजी बिफोर एरिथमियाज नेग्लिजिबल होती है. एवी नोड के अंदर पीआर इंटरवल इंक्रीज़ हो जाता है. परकिंज सिस्टम के अंदर डिक्रीज इन द एंड वेंट्रिकल्स के अंदर डिक्रीज क्यूटी इंटरवल. टी वेव इन्वर्जन ऐसे सेगमेंट डिप्रेशन हो जाता है. एरिथमियाज के अंदर क्या होता है, एट्रियल मसल के अंदर एट्रियल टैकीकार्डिया फिब्रिलेशन, एवी नोड के अंदर एवी नोडल टैकीकार्डिया वी ब्लॉकेट एंड परकिंज सिस्टम के अंदर प्रीमेच्योर वेंट्रिकुलर बीट्स, बाइजेमिनी वेंट्रिकुलर टैकीकार्डिया, वेंट्रिकुलर फिब्रिलेशन हो जाती है. और ये जो है ना हमारे पास ऑटोमेटिसिटी हमेशा डायरेक्ट होती है और परकिंजी सिस्टम के अंदर जब डिक्रीज इन द रिफ्रैक्टरी पीरियड होता है तो वो भी हमारे पास क्या होता है कि वो डायरेक्ट होता है. बाकी सब कुछ जो है ना वो पैरासिम्पैथोमाइमेटिक एक्शन की वजह से हो रहा है. नाउ फॉर द टॉक्सिसिटी ऑफ डिजिटालिस. मेजर साइंस ऑफ डिजिटालिस टॉक्सिसिटीज. ये हमारे पास एरिथमियाज, नॉइजा, वॉमिटिंग, डायरिया हो जाते हैं. रेयरली कन्फ्यूजन और हेलुसिनेशंस एंड विजुअल और एंडोक्राइन एबरेशंस में आकर. एरिथमियाज आर कॉमन एंड डेंजरस. क्रॉनिक इंटॉक्सिकेशन इज एन एक्सटेंशन ऑफ द therapeutic effect of the drug and it is cause excessive calcium accumulation in the cardiac cells, calcium overload. This overload will trigger abnormal automaticity and arrhythmias are noted. Severe acute intoxication caused by suicidal or accidental extreme overdose results in cardiac depression leading to cardiac arrest rather than tachycardia or fibrillation. अच्छा, अब हमने digitalis toxicity को करेक्ट करना है तो करेक्शन ऑफ पोटेशियम और मैग्नीशियम डेफिशिएंसी करनी पड़ेगी. पोटेशियम डेफिशिएंसी को करेक्ट करें often cause a diuretic use. It is important in reducing the chronic digitalis intoxication. Mild toxicity may often be managed by omitting 1 or 2 doses of digitalis and giving oral or parenteral potassium supplements. Severe acute intoxication, as in suicidal overdoses, usually causes marked hyperkalemia and should not be treated with supplemental potassium. Antiarrhythmic drugs. They may be useful in treating increased automaticity, if increased automaticity is prominent and does not respond to normalization of the serum potassium. Agents that do not severely impair the cardiac contractility like lidocaine or phenytoin are favored, but drugs such as propranolol or beta blockers have also been successfully used. Severe acute digitalis overdose usually causes marked inhibition of all the cardiac pacemakers, and an electronic pacemaker may be required. Antiarrhythmic drugs are dangerous in such patients. Digoxin antibodies, or Fab fragments, or digibind. They're extremely effective and should always be used if other therapies appear to be failing. They're effective for poisoning with severe cardiac glycosides in addition to digoxin and may save patients who would otherwise die. Other drugs in heart failure. The other drugs which are used in heart failure include diuretics, ACE inhibitors, beta-1 selective sympathomimetics, beta blockers, PDE inhibitors, and vasodilators. अब हमारे पास diuretics आ जाते हैं. There is a first-line therapy for both systolic and diastolic failure. They're used in heart failure before digitalis, and other drugs are considered. Furosemide is a very useful agent for immediate reduction of the pulmonary congestion and severe edema associated with acute heart failure and for moderate or severe chronic failure. Thiazides such as ACTZ are sometimes sufficient for mild chronic failure, but loop agents are usually preferred. Clinical studies suggest that unlike other diuretics, spironolactone and aflatoxin, which are aldosterone antagonist diuretics, have significant long-term benefits and can reduce mortality in chronic failure. SGL2 inhibitors like empagliflozin inhibit the reabsorption of sodium and glucose in the PCD of the nephron. They have recently been approved for use in type 2 diabetes, and they have been shown to reduce the risk of CVD death as well as hospitalizations for heart failure in non-diabetics as well as type 2 diabetics. Angiotensin antagonists. These agents have been used to reduce morbidity and mortality in chronic heart failure. Although they have no direct positive inotropic action, angiotensin antagonists will reduce the aldosterone secretion, salt and water retention, and vascular resistance. They are now considered, along with diuretics, to be first line for chronic heart failure. Angiotensin 2 receptor blockers like losartan, ARBs, they have appeared to be the same benefits as ACE inhibitors like captopril, although the experience with ARBs is not as extensive. Beta-1 adrenoceptor agonists like dobutamine and dopamine, they are useful in acute failure in which systolic function is markedly depressed. They are not appropriate for chronic failure because of tolerance, lack of oral efficacy, and significant arrhythmogenic effects. Beta-adrenergic receptor antagonists like severe beta blockers like carvedilol, labetalol, metoprolol have been shown in long-term studies to slow the progression of chronic heart failure. This benefit of beta blockers had long been recognized in patients with hypertrophic cardiomyopathy and has also been shown to occur in patients without cardiomyopathy. Nebivolol, a beta blocker with vasodilator effects approved for the treatment of hypertension, is investigational in heart failure. Beta blockers are of no value in acute failure and may be detrimental if systolic dysfunction is marked. Now for the melrinone or the phosphodiesterase inhibitors, they're the representative of the infrequently used groups. Theophylline in the form of its salt, aminophylline, was commonly used for acute failure in the past. These drugs increase the cyclic AMP by inhibiting the breakdown by phosphodiesterase and cause an increase in cardiac intracellular calcium similar to that produced by beta-adrenergic receptor agonists. Phosphodiesterase inhibitors also cause vasodilation, which may be responsible for a major part of their beneficial effect. At sufficiently high concentration, they may be used to increase the sensitivity of contractile protein system to calcium, but they also cause arrhythmias. These agents should not be used in chronic heart failure because they have been shown to increase morbidity and mortality. Now for the vasodilators. Vasodilator therapy with nitroprusside or nitroglycerin is often used for acute severe failure with congestion. The use of these vasodilator drugs is based on the reduction in cardiac size and improved efficiency and can be achieved with proper adjustment of venous return like free load and reduction in impedance to ventricular ejection or afterload. Vasodilator therapy can be dramatically effective, especially in cases in which increased afterload is a major factor in causing the failure. For example, continuing hypertension in an individual who has just had an MI. ANP and BNP are normally released from the cardiac atria and other tissues, and plasma levels increase in heart failure. Plasma level of brain natriuretic peptide is sometimes used to gauge the severity of failure and monitor the drug response. Neprilysin is the enzyme which is primarily responsible for inactivation of the natriuretic peptides. It causes inactivation of angiotensin 2, bradykinin, and several other peptides. Nesiratide is a commercial version of brain natriuretic peptide and can act by causing vasodilation, although it does have natriuretic effects as well. It is given only by IV infusion for acute failure. Nesiratide has significant renal toxicity and renal function must be monitored. Sacubitril is an neprilysin inhibitor that inhibits the metabolism of BNP. It is approved in combination with ARB valsartan. Clinical studies suggest that combination agent prolongs life and reduces hospitalizations in severe heart failure. Chronic heart failure sometimes responds favorably to oral vasodilators like hydralazine or isosorbide dinitrate or both, and this combination has been shown to reduce mortality due to heart failure in African Americans. Calcium channel blockers like verapamil are of no value in heart failure. Now for the non-pharmacological therapy, a variety of surgical procedures to remove non-functional regions of damaged myocardium have been attempted with mixed results. Resynchronization of right and left ventricular contraction by means of a pacemaker have been beneficial in patients with long QRS, indicating conduction abnormalities. Insertion of an Intra-aortic pump is sometimes life-saving for patients with a massive MI and acute heart failure. Patients with coronary artery disease and heart failure may have improved systolic function after coronary revascularization. Transplantation of a donor heart provides a long-term solution in a very small number of cases.